last point which we discussed is that we can have a cervical ectopic. But the more important point is that how to differentiate this cervical ectopic pregnancy from a nabothian cyst. Let's take nabothian cyst first. Nabothian cysts are also in cervix. How to differentiate a nabothian cyst from a cervical ectopic? In your comment boxes now. In your comment boxes now, please hurry up. Sir, please explain unobliterated uterine cavity. Okay, I will come back to this. So now we are discussing the ectopic, cervical ectopic. How to differentiate a cervical ectopic from a nabothian cyst? Hurry up in the comment box. How to differentiate a nabothian cyst from the cervical pregnancy? Yes, now I am getting answers. So Dr. Neha, Dr. Subha, cyst is in cervix wall. Another one, cyst in cervix. Dr. Kailash, nabothian cyst is in wall. Ectopic is in cervix. Dr. Subha. Dr. Bushra, sir, please explain cervical cancer. Madam, please answer whatever is now discussing. So, Dr. Shraddha, nabothian cyst, no residual reactions. Very good. Dr. Anita, ectopic within the canal. Dr. Redmi, so this is not Dr. Redmi, this is a phone Redmi which is reflecting over here. Maybe that candidate is not joined with name. Nabothian cyst has no residual reactions. So, very good points. Now, the point here is that what I have to keep in mind. So, now you have to note down these points. Where are these nabothian cysts? These nabothian cysts are in walls. They are not in the uterine canal. In cervical canal, I mean. If something is in cervical canal, then I will think on lines of ectopic. If that is in walls, that is going not in favor of, that is about a 99.99% nabothian cyst. So I have to see the location first, where the cystic lesion is, whether this is in wall or in the cavity. By cavity, I mean the cervical canal. Point number one. Point number second is that I have to see for the residual reactions. Now, question from your comments. If I am having a cystic lesion, I will say cystic lesion in the cervical canal. Please pay attention. If I'm having a cystic lesion in the cervical canal, this can be this ectopic, I mean the cervical ectopic, or this can be a sac which was detached day before yesterday or some days before in the endometrial cavity high up and has got aborted and has now reached the cervical canal. How to differentiate an aborting sac from a cervical ectopic? Should I repeat the question? How to differentiate a sac which is implanted since beginning in the cervix from an aborting sac which has reached the cervix and is now in the phase of moving out or in abortion? So how to differentiate those two sacs? In your comment boxes now. Hurry up. This is very important point, and we have to differentiate that. Residual reactions in detaching sac. Dr. Subha Patel. Residual reactions in detaching sac. Dr. Subha Patel. Dr. Shraddha. Cervical well-defined echogenic ring. Dr. Subha, think first what you are answering. Residual reactions in detaching sac. No. Where is your ear? I will pull you by ear. Now, Doppler findings have said, I don't have Doppler. I am very poor doctor with an old machine. Don't straightway jump onto the Doppler. These are just excuses that Doppler. Doppler doesn't, I don't have any magical stick in the Doppler. No. Now, decidual reactions in detaching sac, big no. This is the point over here which will be differentiating me from these two entities. Now think first. If there is a sac today, there is a sac which has got implanted into the endometrial cavity. It got detached today. Now I am scanning maybe tomorrow or a day after tomorrow, and this sac has now reached the cervix. Will it have the decidual reactions? When it is in the phase of abortion and has reached the cervix? In your comment boxes, yes or no. Will there be the decidual reactions surrounding the gestational sac which is in expelling mode? Yes or no? Yes or no? Subha Patel, no. Yes, big no. Not only no, big no. This is the differential diagnosis over here. So no, 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 Dr. MS, no, Dr. Neha, no. Very good. Now see the point here. If the sac has reached the cervix, it is expelling, it will not have a decidual reaction. So if the sac is having a decidual reaction in the cervix, that is going in favor of cervical ectopic, not in favor of a sac which is in expelling mode. That is point number one. Keep on noting these points. These are nowhere, neither in books, not on Mr. Google. So that is first point. Second point. If I will be able to find a fetal pulsation, if there is, for the sake of argument, if there is a fetal pole, and in that fetal pole, if I will be able to see the cardiac pulsations, am I dealing with south or north? I mean, am I dealing with the sac which is expelling or the true cervical pregnancy? I am repeating for the last time. Question. Till you will not reply these questions, I will not move ahead. Question is that if I will be able to pick the fetal pulsations, am I dealing with an aborting sac or cervical pregnancy? Think 101 times first before replying, because this is very, very important point. Dr. Asha, cervical pregnancy. Dr. Swapnil, cervical pregnancy. Dr. MS, cervical pregnancy. Dr. Shankar, cervical pregnancy. Dr. Sunita, cervical pregnancy. Dr. Tushira, cervical pregnancy. Dr. Bushra, cervical pregnancy. Very, very good. I love you all. Cervical pregnancy, cervical pregnancy. So the point is, you are now thinking like you should be. If the sac is there since beginning and has implanted in the cervical canal, there is possibility that it will be having the cardiac pulsations. Very good. I am happy that you are now catching things. Part second of the same question. If there is no fetal pulsations, is it going to north or is it going to south? Repeating. If there is no fetal pulsations, will it be cervical pregnancy or aborting fetus? Think 102 times now, not one, 102 times, then reply. Dr. Shraddha, aborting fetus. Dr. MS, aborting fetus. Next. Dr. Kailash, aborting fetus. Dr. Tushila, aborting fetus. I don't love you now. Previously, I told you I love you now. I don't love you. Now you are not thinking. Think first. Dr. Swapnil, maybe both. Very good. Now I start loving you back. Maybe both. Why? Always a cervical ectopic pregnancy will have a fetal pulsations. No. So the point is here that the negative thing, that means the absent fetal pulsations can go there or here. But if it is present, it has to be the cervical ectopic pregnancy. Make a red note in your books. I mean the notebooks. So the point here is that now comes your basket. You have to put your points in your basket. Now here the basket is empty. I have to differentiate it. Now in this empty basket, what I have to put? First point, while differentiating, I mean while differentiating the cervical pregnancy from an aborting fetus, do I have the residual reactions? Now, no, you know what the residual reactions will be. And the second and important point is that if I will pick a fetal pool, and if I'm using word if there is a fetal cardiac activity, that is telling me that this is a pregnancy implanted since beginning here only. Here I mean cervix only. That is why it is having still fetal pulsations if I am getting the fetal pool. Okay, very good. So now what next? So we are taking very quickly these this session, because this ectopic pregnancy is of about 1 week from our server. So we are right now taking a CME, not a course over here. So now see, I don't need to open my mouth now. This is aborting fetus, and this is the cervical pregnancy. In this aborting fetus, I will not see first the residual reactions. Now I'm repeating whatever we have discussed. We will not see the residual reactions surrounding the gestational sac. And point number second is that we will not expect to see any fetal pulsations over here. And if I get any fetal pulsations in this cannot be a sac in an aborting fetus. But if it is a true cervical ectopic, I will be having a residual reactions. And if I pick a fetal heart, that is 101% telling me that, doctor, you are dealing with the cervical pregnancy. There is something which is called as interstitial pregnancy. I have recently means last week only, diagnosed one case. I will show you the clips of that case, but first try to understand what the interstitial pregnancy is. Interstitial pregnancy means that it is neither in the endometrial cavity nor it is in the tube. Now, it will be somewhere in between. This is called interstitial ectopic pregnancy. So there is a gestational sac with a residual reaction located high in the fundus. It will be high in the fundus. These are very important points. We are quickly taking this session because this is not a course over here. This is a CME. So please don't miss any word. So this is high up in the fundus, and there will be less of the myometrium surrounding the sac. Note it down. I will show you later on the pictures of this. So of course, we do have the cesarean ectopic pregnancies. So now let's conclude. Sonographic features of intrauterine and ectopic pregnancy. In intrauterine pregnancy, we will be having a gestational sac with normal shape, size, and ecotexture. Double residual sign will be there. DDS has to be there. Clear embryonic echoes, positive heart rate. But in case of ectopic pregnancy, we will be having a set of uterine findings, which we have discussed. Some will be diagnostic, some will be suggestive. Diagnostics will be the absence of gestational sac in the uterine cavity, and absent of the embryo or its parts in the cavity, and suggestive will be enlarged uterus, thick nano, and the free fluid. And in adnexal findings, we'll be having a gestational sac with or without embryo, but usually we'll be having a mixed solid and cystic mass. This is the problem over here, because not always we are seeing what we are expecting. I mean, the gestational sac with a fetal pole, pulsating fetal heart, not always, but most of times we are seeing these mixed solid and cystic structures. Now, there are some structures which are resembling the ectopics, and one of it is the corpus luteum. Because if I will put a color, that will confuse me, because both will show me color ring of fire pattern. So I should know what wire is, which we will discuss later on. So I am quickly moving in between because we are having a lot of things. Now I am presenting you a case over here. This is the adnexal over here. I am seeing two cystic lesions. Now see, this is one cystic lesion and this is second cystic lesion. Don't see in this cystic lesion. There is something in this cystic lesion. For 2 seconds, don't see this structure over here. So I am seeing two cystic structures, one here, another here. Two cystic structures. Sorry. Uterine cavity is absent. Sorry. Yeah, there is nothing in the uterine cavity. Uterine cavity is empty. And I am seeing in this adnexa two cystic lesions. When I listen to me carefully, when I am putting my probe, I mean the TVS probe, and if I will be putting a TVS probe, I will be having a sliding sign over here. Patient is not much bleeding, but patient is tender. Patient is having a history of chlamydia or anything what will lead to the delay of the transport of the ova. That can be anything which will compress onto the tube, a long tube, tortoise tube, or a broad tube. So there is a history. I'll be fooled if I will not think all lines of ectopic now. Now see, again repeating, there should be some knocking factor on my head. Then only my neurons will think on that line. And that knocking factor is now the etiology and the clinical presentation, which we discussed. Now, what this can be and what this can be, don't see inside this structure. Don't see here. So what this is and what this is in your comment boxes now. Patient is tender, mild spotting. Dr. MS ectopic with corpus luteum. Yes, very good. This is what we discussed. If I am seeing two cystic lesions on same side, one has to be corpus luteum. It is this follicle which has ruptured and now is the corpus luteum, and this is the adnexa in which I am having the gestational sac. Now I will zoom onto this gestational sac. Now I know that this can be a gestational sac, not is the gestational, it can be a gestational sac. Now I will pay attention to over here. Am I seeing a bagel sign over here? Now see, that is dual reaction. Am I seeing a bagel sign over here? Yes, I am seeing. Now I will see carefully inside. Do I see some cystic structure in this cyst? Yes. What is that? What is this over here? Yolk sac. Very good. So it is about 101% diagnosis, not 99.99. This is 101% diagnosis of ectopic pregnancy. Now, if I will put a color on this area, this will show me the ring of fire, and this will also show me a ring of fire. Now I will not get confused. This corpus luteum is not confusing me. Books are writing that this corpus luteum can confuse you. No, I am making it a tool to diagnose this. Is this useful tool? Yeah, this is useful tool. I have seen two cystic structures, and both cystic structures are taking color. So this is actually boosting by diagnosis, not confusing me. So this way you have to see for the now. I will go and I will zoom on. I mean not zoom on. I will go and see this cystic structure detail. I am seeing a yolk sac over here. Oh my God, I'm even seeing something over here. So that is the fetal pole over here. Now see, the fetal pole is over here. And I got the cardiac pulsations from there also. And it was 102 beats per minute. Now, the point is, where from all this is coming? Then I am putting color. Now see, I am putting color. There is a ring of fire pattern. Why it is missing on the top? Why not in the bottom? Because the angle is playing role over here, which we have discussed in our course. I mean the physics and machine settings. So the machine settings and the physics is playing the role over here by not showing me the this thing on the top and in the bottom. So when I put when I put the color on this, I am seeing now the flow, not this, the pulse flow. I mean, what is this called? This is called the placental flow. Put this in your mind and paste it over there. That if I will be taking a color from the flow from the color from the gestational sac, it will show me a low resistance flow. This is called as placental flow. Placental flow. So this is diagnostic of this thing to be a gestational sac and not the corpus luteum. In corpus luteum, we are having a less of the diastolic flow, and here we are having more of diastolic flow. That is called as the resistive index, because resistive index is nothing but the ratio between the systole and the diastole, which we are discussing in our color Doppler course. Now, one sac and one corpus luteum. So I told you that we will discuss it, and we have discussed this. Now the point is, not always I will be seeing a clear gestational sac. Not always I will be seeing this fetal pole. Not always I will be seeing the fetal heart in this. If I see that as 101% clear diagnosis. But the point is, adnexal gestational sac with or without embryonic is seen in this much, and the gestational sac. Now see, the point here is that we are having more of unspecific adnexal mass. This is the most common findings, that is the unspecified adnexal mass.